Hello everyone, this is Dr. Humanist again. Let us discuss about sleep-related breathlessness disorders today. Okay, from the Harrison itself. So there are two things in the sleep-related breathing disorders. One which we all know, which is common, most commonly obstructive sleep apnea, and second is central sleep apnea. Central sleep apnea is like primary due to high altitude. There is hypoxia, and secondly due to medications like opiates or heart failure and all. So today we'll be discussing more about obstructive sleep apnea. So how to diagnose obstructive sleep apnea? So there are two conditions. One, there should be clinical features. Clinical features like nocturnal breathing disturbances in the form of there should be snoring, snorting, gasping, like kind of symptoms. There should not be daytime dyspnea. Remember that only at night time the patient wakes up with the gasping, that is suggestive more of obstructive. If daytime dyspnea, then it goes towards different causes like maybe cardiac cause or other causes. Okay, and plus there should be nocturnal symptoms and daytime sleepiness and or fatigue. Okay, with these symptoms patient should have more than or equal to 5 episodes of obstructive apnea or hypopnea per hour of sleep. More than 5 episodes of apnea or hypopnea per hour of sleep, that is called as apnea hypopnea index. Okay, AHI. Okay, more than 5 or equal to with this, or if single the AHI is more than 15, then is suggestive more of obstructive sleep apnea. So some of the definitions: when do you call apnea? There is a cessation, complete cessation of airflow for more than or equal to 10 seconds with respiratory effort. Okay, so there can be there can be two possibilities. So one is if there is a okay, if there is with respiratory effort or without respiratory effort. If the respiratory effort is present, that it suggests of obstructive sleep apnea. If there is no respiratory effort, that means it's central sleep apnea with apneic episodes. Hypopnea, it's partial cessation of airflow, that is around 30 to 50%. Apnea is complete cessation. Okay, hypopnea is around 30%. Okay, cessation of airflow for more than the time limit, time is mentioned for both is 10 seconds. Okay, or plus there is a 3% decrease in the saturation of the patient with arousal. Okay, which causing distress and which causes the arousal. There's other definitions like respiratory effort related arousal, that is partial obstruction, that is 30% of the more than 30%, and then there should be inspiratory effort using pleural pressure monitoring. It is monitored, and there is association of arousal. Okay, flow limited breathing, when we'll say that flow, the curves are seen and there is scooped out inspiratory flow. Okay, these other respiratory effort related, this is for the staging. Different stagings are used, so these are the different parameters used for that. And if you see obstructive sleep apnea, it is classified as mild, moderate, severe based on the AHI, that is apnea hypopnea index. Okay, 5 to 14 is mild, 15 to 29 is moderate, and more than 30 is severe. Now pathophysiology, what happens is, so during inspiration, so during when you inspire, there is a negative pressure in the lumen. Okay, like pharynx is there. Okay, that airways, they'll have negative pressure, and there are chances of collapsing because there is a suctioning effect because of the negative pressure. So but there won't happen, like when we are awake it won't happen, because there are dilator muscles for that to protect from the collapse, which is controlled by our CNS system. Okay, so the neuro control is there during we are awake. But what happens during sleep is, because especially in the REM sleep, there is a decreased neuro control on these dilator muscles. Okay, pharyngeal muscles, causing the transient collapse, which related to transient apnea or hypopnea like symptoms. So this is the main idea. Now most common location of this collapse is at soft palate. Other than that, it could be tongue base, lateral pharyngeal wall, or epiglottis. Okay, now what are the conditions where which can be triggered because of small pharyngeal lumen? Okay, if there is like fat is there in the obesity patients, or increased lymphoid tissue is there, like tonsils are increased, or genetic predisposition is there, craniofacial problems are there, like some patient will have micrognathia or mandible retroposition, mandible will go back, and that will cause an obstruction. Other than low lung volume conditions. Okay, there is obesity, and in the supine position, what happens, because of the gravity there is more pressure on the lungs. Okay, so even that has like risk factor or prone to have the obstructive sleep apnea. Increase nasal resistance. where you'll see this in the cases of DNS is there, nasal polyps, any obstruction or continuous nasal congestion because of allergic rhinitis. All these conditions will cause increased nasal resistance. Okay, now risk factors, if we see, males are 2 times more affected than the females. Obesity, as I said, is one of the major risk factor for having obstructive sleep apnea. In obesity also, centripetal fat is more suggestive of that, and sedentary lifestyle, supine sleep as a sleep because of the gravity, smoking and alcohol, and postmenopausal, the hormonal changes because of that, age more than 40 years, genetic. So genetics, some of the cases like Down syndrome, Treacher Collins, and hypothyroidism, also, and acromegaly, these are prone for the obstructive OSA. And craniofacial features, as I said just now, micrognathia, mandible retroposition, etc. So clinical features, as just we discussed, most commonly patient will be complaining of nighttime snoring, or the partner who is observing the patient, he'll say that the patient arouses with gasping or snorting like symptoms are there at the night. In the daytime, what will happen is there is a decreased concentration, the cognition dysfunction will be there, memory, attention, everything will be reduced. Early morning headache will be there, dry throat will be there because the patient opens his mouth completely for whole night for the breathing, and there is increased daytime sleep. Okay, so these are the clinical features. Other than that, patient will have hypertension, patient might have nocturia also. Okay, patient will have symptoms of pulmonary artery hypertension. If you see his blood investigation, you'll find that patient might have polycythemia also. Okay, so associated with GERD, okay, hypertension will happen, sexual dysfunction, depression, all the symptoms can also be there with the patient. Okay, now complications of it, metabolic syndrome is one of the complication, stroke is there, congestive heart failure, pulmonary artery hypertension, as I said, systemic hypertension, cognitive dysfunction, sudden cardiac arrest, majorly because of premature beats, excess systoles leading to VT, or asystole directly causing the cardiac arrest. Now metabolic syndrome, as we know, there is a criteria to diagnose metabolic syndrome, more than or equal to 3 of the following. Waist circumference, this in males more than 90, females 80. This data is for Asians. Okay, and this thing, fasting blood glucose sugars more than 100, that is pre-diabetes, or patient is already known case of diabetes or is on medication, and triglyceride levels more than 150 or on antilipids like statins, fibrates, anything if is taking. HDL level in males less than 40, females less than 50, and blood pressure more than or equal to 130/85. So out of +3 of this is diagnostic of metabolic syndrome. Now, how to approach clinical features? You'll see nighttime symptoms, daytime symptoms. Other than that, anything, depression and all symptoms are there or not. History you have to take, genetic history, or any nasal polyps or something like that. Then physical examination, same thing. You have to see for hypertension at the examination. Regional obesity you have to see. Oropharynx you have to check for any polyps or any abnormalities. Nasal cavity you have to check. Okay, and CVS examination, cardiac, because they're prone for having congestive heart failure related complications. You have to do that assessment also. In lab, what you will check, the gold standard to diagnose the obstructive sleep apnea is polysomnography, so also called a sleep study. There are different grades, grade 1, 2, 3, 4. Grade 1, it is done under the supervision. You will be called to the lab, you will sleep there, and they'll check some 7 to 8 parameters of you, like ECG, saturation is monitor, heart rate is monitor, even EEG probe they keep, and electromyomuscle myography, electrooculography, all these things, parameters are studied during sleep. So that is grade 1. Grade 2 is at home. Grade 3 is less parameters. Grade 4 is 4 parameters, 3 or 4 only, the saturation probe and heart rate, and only this. Okay, other than that, cephalometric radiography, upper airway, MRI or CT to see any organic causes, fiber optic endoscopy, etc. And overnight BP, if you check, there will be non-dipping pattern, like BP doesn't decrease at night. Normally it decreases by 10 mmHg, so but in night, in this patient, it won't decrease. Coming to the treatment, main treatment is lifestyle plus behavioral changes, increase the physical activity, stop smoking, stop alcohol. At least if you're the alcohol chronic drinker, you have to tell that don't drink alcohol within 3 hours of sleep. Okay. Sleep hygiene, you have to schedule the sleep and correctly maintain that. You have avoid sleeping in supine position. As I said, the gravity effect, should avoid supine position. Treat nasal allergies if present. Okay, then the main treatment what we advise is CPAP, continuous positive airway pressure ventilation. Okay, it has highest efficacy. Okay, other than that, oral appliances to position the mandible. As I say, if the mandible is retroposition or micrognathia, oral appliances will be there to position the mandible. Surgery, you can go for uvulo-palatopharyngeoplasty. Uvulo-palatopharyngeoplasty. Other than that, the newer advances are injection to soft palate to harden it. Okay, soft palate they will be injecting and then to make it harden. Upper airway neurostimulation. This is one of the advanced techniques. Oh, oxygen by mask for the support. Okay. Now, what are the side effects of CPAP? Nasal congestion will happen because there is a complete continuous airway which irritates the nasal mucosa, and that can lead to nasal congestion, or even dry nose or dry airways will cause this. So what you have to do is nothing, just you should not give the dry air. We should do heated humidification, or you can use saline nasal drops also. Okay, or you can use antihistamine sometimes. Claustrophobia can be there, so what you have to do is there will be big mask which is very discomfort, will cause the discomfort to the patient. You have to change the mask interface, and you can shift to nasal prongs, and you have to practice that CPAP while awake, because it's not easy for the beginners. Okay, with some kind of heavy mask is on your face. Second is difficult exhaling. Okay, because there is a continuous positive pressure, so patient might feel there is a difficulty in exhaling. Okay, bruised nasal ridge, because this is because purely because of the big mask. For that, we can use padding, or you can change the mask interface. And there can also be headache related to this only, or there can be eye irritation as the air is passing, escaping and going to the air, causing dry air and the dry air irritation. You have to position the mask correctly. Aerophagia can be there, that is air swallowing, which can lead to bloating and gastric symptoms. For that, you can use antacids. Sometimes if you don't clean the mask, actually they are been taught about how to clean, when to clean, and when to change the mask. Okay, depend on which mask they're buying. Usually 6 months or like 8 months they'll be changing the mask. If they don't clean it, then it will cause sinus infections like sinusitis. Okay, this is the topic of OSA. There is one more sleepiness scale, which is called as Epworth sleepiness scales. There will be nothing but 0 to 24 score. This thing are there, scores are there. It's a questionnaire. They'll be asking about sleepiness, like when you're getting sleep during reading, or you're getting sleep during watching TV, or you're having lunch. So based on that, the patient subjective test, patient has to marks 0, 1, 2, 3, 4, and based on that they'll diagnose OSA. So more than 10 score is a diagnostic of OSA. Thank you.